Hello, good afternoon to Chatham House members. Welcome to Chatham House and this second members event looking at key developments in the US election. I'm sure you can't have failed to notice in the news this morning that we had the first presidential debate on television last night. People still reeling from that. One of the big issues that was discussed very early on in the debate and led to some of the most heated exchanges was that of healthcare and the future of healthcare in the United States. So we thought it very opportune to have a discussion, a members event, looking specifically at the healthcare debate in the United States, which of course has been really magnified in its importance by the COVID-19 pandemic, which has hit the US very hard with, I think, in excess of 200,000 fatalities already sweeping across the US. So today I'm absolutely delighted to have two wonderful presenters, speakers, who I know very well and are great sort of pioneers of universal health coverage in the United States. We have Dr. Abdul El-Sayed, who is the author of a fantastic book called Healing Politics, a doctor's journey into the heart of our political epidemic, and was the head of health in Detroit and ran for governor of Michigan on a progressive ticket, very much focusing on access to healthcare. So Abdul's been right in the thick of the debates going into the election campaign. And also we have Cheryl Cashin, who is the Managing Director of Global Health Practice at Results for Development and is an expert on health systems across the world on particular health financing, and has been very active in the debates about particularly the future of healthcare in New York, where she's based. Without any further ado, I'd like to bring in my panelists, and I'd say who are tremendous experts on the US health system, and really to sort of set the scene, if I may, ask you for your thoughts on what are the problems with the US health system, and how would you ideally like to see it reformed? We heard a lot of mention about this last night in the debate, and lots of sort of talk about different options for the US health system. So Abdul, maybe if I could start with you and ask, were you president of the United States, and perhaps one day you might be, how would you like to reform the US health system?
No, don't wish evil on me, all right, Robert? Look, there are a lot of problems with healthcare, and let me just start by telling you a story of a woman who I got to interview for a podcast I host called America Dissected, and I think she's emblematic of so many of the challenges that we face. Her name was Lisa, and she was 33 years old. She was on vacation with her husband when she felt a sharp chest pain. It turned out she was having a very serious but very rare form of a heart attack that's uniquely suffered among young women. And thankfully, she got the life-saving care that she needed. But she was in a rural community and happened upon the closest hospital happened to have a cardiac unit, which she was very lucky to have, because many times, first of all, rural hospitals are closing, and second of all, very rarely do they have specialty care. Her family is insured. They have private health insurance through her husband's employer. But 3 years before that, her husband had a brain cancer, and he has to have quarterly MRIs to make sure that the cancer hasn't recurred. That means that they chew through their deductible, which is the amount of money you have to pay after you pay what they call a premium, which is every 2 weeks or every month, to the insurance company to keep your insurance coverage. Their deductible is like $7,500 a year. And when he had first had his brain cancer, it was about $14,000. They had gone so far into debt just to pay down that deductible the first year that their family had to have an in-person fundraiser, and they launched a GoFundMe. But every year now, they are stuck paying that added deductible. And all of this is because the cost of healthcare in America has increased, and in order for there to be a reduction in the sticker price, they'll say, what has happened is more and more of that cost has been pushed back in the form of these cost-sharing mechanisms that include a deductible or co-insurance or co-pays, meaning money that's coming out of people's pockets. And all of this is because in our system, we have multiple payers and multiple providers. And you sort of think of yourself as being a customer of healthcare, and Americans love to think of ourselves as customers for things. And the problem with that is that, when you go to the grocery and you want to buy, let's say a head of lettuce, right? You pick your head of lettuce, you take it to the grocery clerk, they scan what it is that you bought, and then they ask you for money. A financial transaction happens between you, the customer, and the grocer, who's the seller. In the American healthcare system, you aren't exactly the customer, because every time you get sick, there is a financial transaction, but it doesn't happen between you and the seller of the good. It happens between some insurance company and the seller. And so if you're the reason why a financial transaction occurs in the current system, you're not actually the customer, you're the product. You're more the head of lettuce than you are the person buying the head of lettuce. And as negotiations occur for prices, because you have multiple payers and multiple providers in the system, this negotiation is not incentivized to reduce the cost for you, because you're the product, right? Head of lettuce doesn't care what it costs. It's incentivized to increase the competition, or to decrease competition, and to try and consolidate your role in the market, which means the costs then continue to go up. And so that you're none the wiser. They change the sticker price on you by adding these deductibles and co-payments, so that you still think that you're paying a cost that is affordable, when in fact it just hits you on the back end when you get sick. So all of that leaves us less insured, 10% of people uninsured in our country. The costs of care are too expensive and continue to go up. There's no incentive for prevention of your care, and it's the leading cause of bankruptcy, even among people who are insured in our country.
Yes, that's pretty bad, isn't it? And and it's ironic, because the idea is there's sort of free markets and competition. This is meant to drive pricing down. This is the misnomer. This is, and I think lots of people find it quite extraordinary that all this multiple purchases, and this is meant to be one of the great features. This idea of choice can actually push prices up. Cheryl, if I can maybe bring you in on this, you're a health economist. What's your take on the ills of the system, and maybe how it should be reformed?
Great, and thanks, Rob. Thanks, Abdul, and hello, everyone. I think you just said it really nicely, Abdul, what the consequences are for people like us of our system. And it's just dreadful to have to need to use healthcare and not to know what kind of financial risk you're entering into. It's just, the consequences are a nightmare. And maybe I'll talk a little bit about the causes. And I think working globally and working in many health systems at all income levels, I can say the US is the only healthcare system that does two things. One is to tie your coverage to your life circumstances. Are you employed? If yes, good for you, you might get that kind of coverage. Are you elderly? Good for you, you might get that kind of coverage. So your life circumstances determine whether and what kind of coverage you get. And that's a big problem, as we're finding, especially in the time of the pandemic, when 30 million people lost their jobs. The other feature of our healthcare system that I have never seen in any other country where I have worked, and that is financing it through a for-profit mechanism. Health financing for-profit through private insurers. That's not a part of the system where you make a profit in other countries for a lot of reasons. And then that ties to our for-profit service delivery side, as the higher levels of that, where there are big corporate hospitals and conglomerates, that they are really working together hand in glove, the private insurers and the private providers, and that helps to drive up the costs. And these are not features you'll find in any other country for all of the reasons that Abdul says. The consequences of that are just terrible for healthcare and for the financial health of families. So I've been kind of working on the periphery or deeply engaged in health reform way back to the mid-90s, where most of my mentors in the mid-90s were working on the Clinton health plan. And that failed, obviously. Fast forward to the Obama Affordable Care Act. And it's a series of attempts to twist our health system around this private insurance sector and try to make it work with regulation or something, that we accept it as a given that this layer has to be there. And I do not accept that anymore. I think at this point, I am convinced that there is no way to keep a role for the main part of our essential health coverage to be with the private insurers. They will always find a way they made bigger profits than ever after the Affordable Care Act, only until recently when they made even bigger profits because of the pandemic. So as they collected their premiums and didn't pay out to hospitals and doctors because no one was utilizing care, elective services were delayed, they kept those profits. And so I think I don't agree anymore that we can make that work. And so I would like to see a single payer system like is being proposed in Bernie Sanders' Medicare for All bill, that is envisioned in the New York Health Act that I work behind, that we have good evidence in our country that Medicare works, it's efficient, people get good quality care, and people are satisfied with it. And I think we can talk later whether, how politically feasible that is in the current climate, but I feel very strongly that we need to move away from the idea that we can make it work with private insurance.
Thanks, Cheryl. And Abdul, I know that you're just about to publish a book called Medicare for All, A Citizen's Guide. So could you sort of give us, to our citizens, our Chatham House members, just a very potted version of, what it's going to involve in the US to move to a Medicare for All single payer system?
Yeah, and I really appreciated Cheryl's point. The challenge we've had for a long period of time is this governing consensus in the United States that the market has to be part of the solution, when in fact that has meant the destruction at every turn of public goods to offer solutions to people, particularly low-income people, but everyone, and rising costs across the board. It's not just healthcare. I mean, healthcare is one example of it, but when you talk about infrastructure or housing or the economy itself, you've seen this same governing consensus that has led us astray. So what is Medicare for All? It is as Cheryl talked about, a single payer healthcare system. And what does that mean? To use that analogy that I used about the grocery, you have payers on one side, there are 7,000 of them or so in the United States. And then you have providers, like they're the folks who actually give you healthcare, the doctors and the hospitals. And right now, what's happening is that you have this negotiation over prices between payers and providers that leaves the actual people who get healthcare left out. And what a single payer system does is to say, instead of having 7,000 of these folks who are motivated by profits, what if we just had one payer? And that payer was the federal government, a single payer. And what that single payer does is a couple of really, really important things. Number one, it covers everybody. Everybody would get healthcare through the single payer, decoupling, as Cheryl, I thought, really eloquently put, decoupling your life circumstances from whether or not you can get healthcare. Number two, though, right, you now have what's called a monopsony. Everybody knows about a monopoly, right? A monopoly is one seller of a good who can then fix the price because they're the only place you can buy it. A monopsony is one buyer of a good who can also fix the price because they're the only people buying. And so if the government becomes a monopsony for healthcare, what that does then is it holds these payers accountable to rates that are fair, and it addresses this sort of playing off of each other that's happened in the multi-payer market to raise the costs overall. But then the other part of this is that, having worked in healthcare as a student, right, you see the army of billers that has to exist for 7,000 different insurance companies with 7,000 different codes, and hundreds of thousands of different hospitals and doctors. Each of them, right, is paying an army of billers to be able to crosstalk. But if you have one buyer of healthcare, right, that army goes away on both sides. And so that reduces a lot of the overhead costs of American healthcare, which are so high. And then the last point, right, is in one that I'm really passionate about as a former health director, is that in our American system, there is no incentive to invest in prevention at all. Why? Because, to use that grocery store analogy, right, for there to be money exchanging hands, which of course, if both sides have a profit motive you want to do, people got to go to the market in the first place. That means people got to get sick. And so there's really no incentive to prevent disease in our system. And you see the consequences because we were flat-footed. Our public health apparatus has not been invested in a meaningful way over the past 20 to 30 years. And our public health apparatus was caught flat-footed. And part of that is because we have a president who doesn't know what the hell he's doing. But part of that is also because the agencies themselves have been underinvested in and underfunded. And so the reason why we have no incentive is because you have 7,000 different insurers. And if people are going to jump between these insurers, if one insurer were to make an investment upfront in preventing disease down the long term, the high likelihood is that that money saved is going to accrue to another insurer. So you have this collective action problem around prevention. And so in a single payer system where the government is both the one who would save on prevention and also the one who would invest in prevention, there's far more incentive across the system to be investing in preventive care. So it reduces the cost of healthcare, covers everybody for curative healthcare, and creates an incentive for prevention.
Thank you. Thanks very much, Abdul. And just to remind members that do please ask questions. If you go into the Q&A and ask questions, then I'll come to these in a second. But I'd just like to sort of pose another one to you about what's likely to happen. The probability of sort of moving towards this universal publicly financed system that you're both advocating, and of course a system that we're very familiar with in the UK when you're sort of describing this phenomenon of a single payer and not having to worry about healthcare costs, depending on your circumstances. We in the UK, that's what they're used to, the sort of the cradle to grave coverage of the National Health Service. But the US health system is very, very unusual. You mentioned it yourself, Cheryl. People sort of, I think, tend to assume that a model of private insurance is quite common, but there are very few countries. One thinks of the United States, South Africa to some extent, which is a hang-up from the apartheid years. There are only a few other countries where the private insurance has become so dominant. So, the big question is, how is this going to change? Do you think it is likely to change? You might sort of say that's going to depend on what happens in the election in November. But I'm even wondering, and specifically to you, Cheryl, that might it come in state by state? That one's seeing one or two progressive states maybe getting ahead of the pack, really, in sort of pushing through acts at a state level. Do you think that's a feasibility? How do you think the US might move towards Medicare for all?
Oh, well, there's what I hope happens and what is probably more likely to happen. I think the sense is, at least, I just spoke to our elected official yesterday in New York, our local official, and the sense is that Medicare for all versus improving upon the Affordable Care Act was adjudicated in the Democratic primaries, and Medicare for all lost. And that's their sense politically. And I think, that may be true, across the country. And when I'm out working on the New York Health Act and speaking to people where they get stuck, where the narrative has been effectively taken against Medicare for all is three things. Like, one is that it's socialized medicine, that we haven't communicated well enough, that we're talking about financing. We're not talking about the service delivery side, which will hopefully be better organized, better utilized, more efficient, but we're not making that public in these proposals. But people can't make that distinction between, a government-run plan financing versus service delivery. And then the second place where we failed to communicate effectively is on the issue of choice, that somehow the message has gotten through that Medicare for all reduces choice. Yes, it reduces choice of insurance plans, but that's not where people want choice. You want choice of your doctor and hospital, which is actually much broader under Medicare for all, where every doctor and hospital is in that one plan. They're all in network, so to speak. And I think the third place where we have lost the narrative is on how you pay providers, that there's this idea that we would starve them. Everyone's going to get paid government rates, so our top-notch hospitals will not be able to succeed, or they will leave. And if we put 18% of our health spending back into healthcare, not into profits for private insurers, that gives us a lot more money to work with to pay effectively. And no one wants to, and I spoke again to our elected official yesterday, said, Cheryl, I would not support a health plan that starved our community hospital. It won't happen, but we just haven't communicated that effectively. So I think we may have lost the narrative for now. If Joe Biden wins, inshallah, we will have an opportunity to improve upon the Affordable Care Act. And I think that's the most likely direction. And that will probably make it harder for us to get the New York Health Act passed, at least in the next year or so. But if he loses, which I shudder to think, we will probably have a lot more opportunity to work at the state level. So I don't know. I hope for the first one and using the opportunity to to continue to work in New York to continue to show that a single payer system is feasible, even if at the national level, our most likely opportunity is to improve upon the Affordable Care Act.
Sure. And if I can ask you both, maybe, sort of, I was looking at the debate last night and, hearing the discussions about the public option and what that means for the, people's sort of choice to stay on their private insurance and move to a public option. Do you think that the sort of the tactics are that if one makes the public option very attractive and subsidize it a lot, that almost by stealth people are going to switch over time and you're going to see the change in balance? Is that the strategy, would you say, Abdul? Because sort of one feels that it's still sort of tinkering around the edges a bit, but are there ways, do you think, the public option could become the most popular option very quickly?
Yeah, I want to echo one of the key points that Cheryl made, which is that this debate has been framed largely by the insurance corporations. And one of the things that folks have to understand about why our healthcare system is so broken is that it is fundamentally connected to why our political system is so broken. And that's that it costs millions, if not billions of dollars to run election campaigns. And there is a very devastating Supreme Court ruling, which which basically interprets money to be speech and corporations to be people, and therefore disallowing corporations to put money into electioneering would be like robbing somebody of their free speech and robbing them of their First Amendment rights under our Constitution. And that is an extremist interpretation of both the First and 14th Amendments, and it has hijacked our political process to allow literally billions of dollars of financing from corporations to, in effect, buy off our politics. Now, to put this in perspective, over the past 20 years, the number one and number two biggest lobbying industries were the pharmaceutical industry and the insurance industry. The pharmaceutical industry spent $4.4 billion lobbying politicians over the past 20 years, and the insurance industry spent $2.6 billion lobbying politicians. And that's not including electioneering spending. That's just lobbying spending. And so, the power of corporations to shape the debate through what they've done to lobby politicians, but also through what they've done just to frankly advertise and frame the debate, has left people, talking these sort of broken talking points about, it taking away choice, or it costing us too much, or it bankrupting hospitals. And you have to understand the way that the system works is that it feeds that conversation, and people then take those talking points and use them against Medicare for All. Nevertheless, right, if you look at poll after poll after poll, particularly in the context of this pandemic, Medicare for All and single payer healthcare, right, literally government healthcare, and that's, they ask it in certain polls, has never polled better. 60% of Americans think that this is a great idea. The challenge here is to shift the politics so that they match what the population believes. And if you sort of take that Citizens United Supreme Court case and recognize it for what it is, which is a violation of the terms of our democracy, it explains the decoupling between public opinion and what our politics is doing. I do agree, though, that we have an opportunity moving forward. It really does depend on what happens in November. And if you look at, I was one of 8 people who served on the task force that brought together sort of the Bernie wing of the party and the Biden wing of the party to sit down and think about where we're going next. And the way that those of us who believe in Medicare for All thought about what the platform ought to do is, number one, we know that Joe Biden is not Bernie Sanders, however much you had to sit through that. All of you, I'm really sorry that you had to sit through that debate if you watched it. But as much as Donald Trump is trying to label Joe Biden as Bernie Sanders, we assure you he is not. And also the question that we wanted to ask ourselves was, number one, what takes down the vice grip of corporations on our healthcare system? Number two, what provides most people access to coverage? And number three, what expands the public footprint of healthcare? And then number four, what decouples the employment system from the healthcare system? And the public option that Joe Biden is running on is a truly public option, meaning it's not just a program that corporations can buy into. It really is owned and operated by the federal government. Number two, it would be fully subsidized for people earning less than 200% of poverty. So a family of four earning $52,000 a year would basically get it for free at the front end. And it does create an option for anyone, independent of their circumstances. Now, do I believe that it goes far enough? No, I don't, because it leaves in place those 7,000 private health insurance companies who are the reason why our costs continue to go up. But it does move the ball down the field in that direction. And, if you compare it to what Donald Trump wants to do, which is, obliterate the ACA and not really replace it with anything, which would leave millions of people without healthcare, 23 million in the middle of a pandemic, it is clear to me that it is a step very much in the right direction, considering I'd rather be walking I want to run forward, but I'd rather be walking forward versus being dragged on my rear end backwards if given the choice.
Yeah, thanks very much. In fact, you've just answered one of the questions that Dina Mufti asked about pharmaceutical and insurance companies lobbying Congress, and that's affecting the decision making. And you very eloquently put the scale on that. I think it's up there with the gun lobby as well, isn't it? In terms of the most lobbying. So thanks for answering Dina's question there. She actually asked another one as well that I'd perhaps like to put to Cheryl. Which sort of country do you think the US could move, model its health system on? Sort of bearing in mind where you are at the moment, maybe to lurch over to a UK style NHS might be, sort of too much in one go. Abdul's already sort of mentioned some options about sort of getting there. But I mean, do you see from your international experiences, maybe a sort of a halfway house that you think the US could move to quite quickly?
Thanks for that question. I think it's been a really interesting discussion, how much Americans are willing to look at international experience to get inspiration to reform our own systems. And coming into the domestic dialogue from the global perspective, I've been shut down quite a lot trying to make those comparisons, who can we look to? And I think looking at features is probably a better way. And what features can we adapt to the realities of the US health system? When we looked at, I think I read some of the congressional testimony when the Affordable Care Act was being debated, and they're really looking to the Netherlands, that this is like the closest thing. And they have private insurers, they're able to tightly regulate them, and they're able to do all the things of a single payer system, but with these private players. That doesn't work. And I think we kind of went down that road. And so I don't think trying to model ourselves to get closer to the Netherlands, we're never going to be able to regulate the private insurers the way they can in the Netherlands. So looking at some of the features, looking at the countries that have universal access with lower costs, they have a single or fewer payers, they have, some of these features that just take you back to Medicare. Like, we have the system, it's there, it works. And so I think how we get from that, just serving a fewer number of people to serving more. And Abdul, I really, really congratulate you guys on that proposal, that Joe Biden, that compromise position. I think, looking at the numbers, you are getting closer in a lot of ways, expanding the subsidies, expanding the number of people who are eligible. I think the numbers that I saw, that there would be quite a significant number of people who would actually pay less joining the public option than they currently pay through their employer. So you could probably even peel away some people in that situation. So I feel like we have to take the part of our system that works and try to get more and more people in that direction.
Great, thank you. And if I maybe go to one of the audience members, if Carolyn is happy to sort of ask her question, or otherwise I can ask it on her behalf. So I'm not sure if it's possible to unmute Carolyn Klein.
Yes, that's me. Can you hear me?
Yes, very well. Thanks, Carolyn. Please ask your question.
Yes, well, my question is, given the current pandemic, what are some of the consequences for the US healthcare system should, hopefully not, Donald Trump get re-elected?
So the doomsday scenario, what happens November the 4th if Donald Trump's re-elected to the US health system?
So there is 2 weeks ago, we lost an incredible human being and one of the greatest jurists in our country's history in Supreme Court Justice Ruth Bader Ginsburg. That kicked off a violent effort to undo the precedent that they had set when they denied President Obama his constitutionally mandated Supreme Court pick. And the Republicans decided that even though they had said that because he was in his last year, they wanted to leave it up to the American people to decide, they are now rushing through a Supreme Court pick. Donald Trump has nominated a lower court judge named Amy Coney Barrett, who has a record of decrying the Affordable Care Act and also Roe v. Wade, which protects abortion rights in the United States. And on September 10th, the court is set to hear a case called California versus Texas, which in both lower court rulings has deemed the Affordable Care Act unconstitutional. If they fill the seat and they have the votes to fill the seat before Election Day, the new justice would be sitting on the court that would then be hearing that case. The last two challenges to the ACA in the Supreme Court upheld the ACA, but by a 5-4 decision. And one of those 5 was RBG, Ruth Bader Ginsburg, and she would have then been replaced by this new judge, which all indications show will side against the ACA. If that happens, the ACA will be deemed unconstitutional and will be struck down. So even independent of the election, there may be time where the ACA is no longer the law of the land. If Joe Biden were to win, that would then leave the next administration, hopefully with a Democratic Senate majority as well, in a position to pass comprehensive healthcare reform that would likely, go beyond what the ACA did in terms of providing public care. But if he doesn't win, the high probability is that they will not be able to pass any real healthcare legislation, meaning we'll be going back to the bad old days. All of that suggests that about 30 million people, including the people who lost their health insurance during the pandemic, plus the people who would lose their coverage to the ACA, would have been added to the uninsured rules, meaning that we doubled the number of people uninsured in our country from 10% to 20% right there.
If I could add on to that, please, Abdul,
Please,
thank
yeah.
you for that. Just, that what we lose sleep about, all of us. I did discuss this with our state legislators yesterday. In the event that the ACA gets struck down and Joe Biden doesn't win, does that also mean that the state level initiative would be unconstitutional? And he said, absolutely not. He said that we would be able to, under the state's rights, that they do have the right to protect the health and safety of their residents. And so a law like the New York Health Act could still go through. So the action at the state level at that point would become very, very important.
Mm-hmm. And could I ask, what one looks, I've been sort of following the debates in the US, including in New York, but what other states might be able to do something like that? One's conscious that, people like Governor Gavin Newsom in California sort of came to power on a very progressive health ticket. What would be the other states, do you think, that, to watch that might sort of go it alone?
So I would say California is the one to watch. And, California has 53 million people. They're the 5th largest economy in the world. So that's a huge deal right there. And the others might be Oregon. I could see trying to do it. I could see, New York, of course, in a nod to Cheryl's good work. When I ran in Michigan, we ran on a single player platform. Obviously, I didn't win. But I think you're going to start seeing a lot more interest in doing something like this, particularly if the ACA falls, because the forcing function is critical. There is one point, and I'd love Cheryl's perspective on this, because it's a point of a technical point. There is a waiver called a 1332 waiver in the ACA that allows the federal government through the Centers for Medicare and Medicaid, who run the federal government's public insurance programs for the elderly and for low-income people, to basically take all the money that the federal government gives to a state, bundle it up, and allow the state to offer, a single payer program or some other innovative approach to health care. The hard part as a state for being able to float a single payer program without that waiver is that states constitutionally are mandated to have a balanced budget every single year. They can't take on debt. And if you can't take on debt, financing healthcare becomes really, really a lot harder. And what 1332 allows a government in effect to do is to take the debt that would be generated and push it off to the federal government so that you can have this kind of approach and you have the sort of federal government as a bank helping you to finance. The question, is in the absence of the ACA, depending upon how broad the ruling is, what happens to 1332, and what is the participation of the federal government in doing it? And one of the pushes back, just as a point, was that when I ran on my single payer platform, they said, well, you're never going to get the Trump administration to give you a 1332 waiver, right, to be able to pass this forward. So how you go about promoting a state-based, insurance reform, really, in some ways, it ties to what the federal government is interested in doing. And so, Cheryl, I'd love to hear a little bit more about how you guys are thinking about doing that in New York in the absence of that waiver, or if there's an alternative way to think about it.
Yeah, Cheryl, please. Have you addressed this? Where are you going to get the money from?
Yeah, no, thank you. And thank you, Abdul. This is something that we struggle with. We were actually struggling with it 2 years ago when we thought we were going to try to pass something while Trump was still president. And this issue came up front and center. How are we going to get the waiver? And so the legislators have been working on workarounds. I'm not sure that they addressed the issue that you raised about the debt, but they did try to come up with something where even if you couldn't pool all the funds, you couldn't actually have everything behind one plan, you could make Medicare, Medicaid, all of this adjacent, and somehow, we call it virtual pooling in our world, but somehow make it operate like a single plan, even without a waiver. But I have to follow up on that question about the debt. I don't recall that being specifically discussed, so that would be, really a big challenge, but I will look into it.
One interesting approach.
We're not going to count on the waiver if he's there. Sorry.
Yeah. No. One interesting approach that we'd sort of thought about was like regionalization. So you can imagine, right, the pool of money that allows you to to create a cushion gets bigger the bigger that the pool is. You're basically generating an insurance pool. The bigger the insurance pool, the more laxity you have in the insurance pool. And so it's interesting, right, to think about like what would happen if you had regional governments come together, or even just coalitions of states that don't share borders come together to try and create some sort of sharing. One thing that was really interesting is that thinking about on the pharmaceutical front, right? There has been one of the big issues in our country is that Medicare, who's the single biggest buyer of prescription drugs, is legally mandated to be unable to negotiate with pharmaceutical companies for the price of drugs. And one of the things that Joe Biden is running on that we were able to come together around was addressing that, so that in fact Medicare could negotiate prescription drugs for everybody. But one interesting question is thinking about can you get a compact of states who come together and negotiate together for prescription drugs? And so some of these sort of these coalition building exercises that unfortunately we've had to see happen to get any sort of purchase on COVID-19 in the absence of federal leadership may come into play in the worst possible scenario where Donald Trump takes a second term, and I use the word takes in very, very purposely.
Sure. Yeah. Now I think we have another question from the audience. Nina, would you like to come on and ask your question to the panel?
Hi, yes, thank you very much. It's actually been discussed already a little bit. So if I may, I would change my question a little bit in terms of, we've talked about COVID-19 being some type of stress test for the US system. It's shown to sort of lack in social protections for people. I think there was a Gallup poll around April that 13% of Americans would still not access treatment or testing. So just wondering how this narrative can feed into advocacy for better health system for all Americans, and sort of dispelling that myth of this private system being more efficient, which is a pervasive myth, as I often talk to American students about this. Thank you.
Thanks, Nina.
Well, I'm happy to just say, Nina, thank you for raising one of my biggest pain points in this era of the pandemic. If there were any silver lining, I thought it would be the chance to connect the dots between the failure to address the pandemic and our systemic failures in the health system, and people who are living through it could see that. That has not happened. And there has been a disconnect in the way we talk about this in the media, even the way the politicians are talking about it, at least in my state. And I think it's a really big lost opportunity. And what I was told is just that they think people are overloaded and can't absorb all of that information and that big picture connection. I find it really unfortunate that not to take this opportunity to make those connections.
That's extraordinary. Yeah, Abdul.
And I was just going to add, I think, it is one of the ways that that the Trump administration and his politics has succeeded in owning the message around COVID-19 is to treat it as an aberration, like just this thing that came out of nowhere, like a comet that hit the United States. And the virus is a biologically evolved thing that nobody created. The pandemic is man-made, and that's something that I think we have to keep hitting. And interestingly, right, it's not just, and I don't use the word just to minimize, but it's not just that people were left without health insurance, were left without housing, or were left without employment. It was also the fact that the healthcare system itself failed the COVID-19 test. I mean, there's a great article in the New York Times that I recommend everybody read about the political process and the corporate process around creating a ventilator stockpile. And the CDC had worked with a small company that they awarded a grant or a contract to create the stockpile of ventilators. And you can't make this stuff up. The company that bought the smaller company decided that it was no longer profitable for them to continue forward in this line of work. So they just dropped the contract, even though that they'd already used some of the money. Now, here's the crazy thing. The name of the company was called COVIDian. I mean, literally, if you're going to write it in a novel, like, you couldn't write any better. All the PPE that we didn't have, right, in our country, that is because we have allowed our system to function so clearly as a for-profit venture that, you get consultants who come in and say, well, listen, you shouldn't be stocking this much PPE. You don't need it. You need just-in-time supply. Just-in-time supply means you have no time in the context of a pandemic. So, like, all of these ways that our healthcare system was broken. A third one, right? You had hospitals that were literally going bankrupt in the middle of a pandemic because they lost all of the money that should have come in through all of their elective surgeries. That is their lifeblood. And so the hospital's never been busier and is now facing bankruptcy in the middle of a pandemic. Like, the system doesn't work. And so there is a responsibility, I think, that people who talk about this and think about this have to continue to push and say, this is not an aberration. This is not a comet that just hit us and we weren't ready. This was about our failure to prepare and to prevent. And we have a responsibility to fix that. And it means that we got to go back to the system and ask, how do we make it better? It shouldn't be large corporations that just can buy a smaller corporation and then fail the government who's given them a contract. There shouldn't be a circumstance where your hospitals are going bankrupt in the middle of a pandemic. Doctors and nurses and hospital staff shouldn't have to wear garbage bags in the richest, most powerful country in the world. Like, these are things that should never happen. And we've got to keep talking about them that way.
And if I might sort of just finish with, I'm afraid we've hit our time limit, but there's a burning question that I'd love to ask you. We sit here sort of incredulous at the situation and really sympathise for the plight there. Cheryl, you've already mentioned, this issue that, the reluctance maybe for people in the US to look outside, to look to other countries. Now, the whole world has signed up to universal health coverage at the UNGA, and the trend across the world is undoubtedly towards a publicly financed health system. The US is this extraordinary outlier in being the biggest economy that hasn't done this yet. But what can the global health community do? I mean, we'd love to help. And I think, were the US system to become a publicly financed system, it might stop polluting health systems in other countries with some of this ideology. So it's in all our interests, I think, that the US does move in this direction. But is there anything that we can do? Because it might even be counterproductive from what you're saying, that if we start coming in suggesting that you say the old colonial power knows better and stuff like this. So what do you think? Do we just sort of sit and wait for you?
Rob, I think something sums up the Americans' attitude towards just solidarity, towards reaching out to global partners and experience, is that the mask, a public health measure to protect yourself and others, has become a symbol of freedom. And you can't take away my freedom. I'm not going to wear a mask because you're taking away my freedom. So that just connects to every other thing that we're talking about here, because universal health coverage relies on solidarity. It relies on, committing to something that is a joint objective. So to take that even beyond our own borders and to think that we have a responsibility to other countries also to have a health system that functions and doesn't pollute the health universe. We're further away from that than we were even before the pandemic, and that's something that makes me very sad. And I think using examples of what other countries have that we could afford, I've tried it from every direction, comparing side by side the South Korean response to the pandemic versus ours, because we had our first cases identified on the same day. None of it resonates. And so I'm going to take up your question as a call to think about this and how can we make better use and access to our global partners to help to change the conversation somehow in the United States. But as of today, standing here, I don't see that entry point.
I mean, it's interesting that the elders, both did events on UHC in New York and California, where they were talking about their experiences. And I remember Ban Ki-moon sort of talking about the transition to UHC in Korea, actually. But that felt very much like preaching to the converted. It was largely a Democrat audience that came along, and one just wonders what it takes to sort of to change the dial. Abdul, have you got any thoughts on how collectively we can help, if at all?
Yeah. So number one, I think we're coming. Like I honestly, I know that this moment, especially if you watch that debate last night, feels like it's all going to be lost. I think we're coming. I think, I talk to young folks all the time, and if you're younger than 30 in this country, all you've seen is the system fail, and they are the future. Our job is to protect the democracy so that as they come up, that they build the future that all of us need, deserve, require, and should have had a long time ago. There are uniquely American challenges to doing this. There are uniquely British challenges that you guys faced. There were uniquely Korean challenges. And the challenge with being the country that we have been, and the size and scale and scope, is that when you fail, the world watches and takes notes. I do think, though, that we are coming, and I think the way to be helpful, to be honest, is to continue to call upon America for leadership and to note when it fails, right? Because I do think that there is something that we do pay attention to about this notion of our responsibility in the world, and so much of the painful history where we've gotten it wrong, but also some of the good history where we've gotten it right, and that we have an opportunity and responsibility to do this for our people, and also to do this to secure a global health agenda abroad, right? Like what COVID-19 showed us is that a virus that makes a jump into humanity in China can kill hundreds of thousands of Americans, and so we have a responsibility to engage. Now, if God willing, we have a leadership change in the next month, the next question will be, how do we? And I think Biden's call this, how do we build back better? Is going to be an open question, and we are going to need the international community to reach back out and to say, all right, here are the things that you guys got wrong the first time. This dude came in and broke them. Now, how do we fix them so that they're not breakable, and that they are better this time around? And I think you're going to find a lot of willing people on the other side. I believe deeply in our country's ability to correct. It is the thing that is, I think, the most beautiful thing about our country is, a son of immigrants who was a junior during 9/11. Our country does, we stumble sometimes and we get it wrong, but we do have the capacity to get it right. And that work, I think, is the work of the future. So it takes all of us to do that.
Fantastic. And thank you very much. Yeah, Joe.
So I just want to say thank you for that. Thank you for making me feel optimistic for the first time, certainly lately. So I believe in your work and your energy, and really we look to you.
Yeah. Well, I appreciate your leadership too. And
I think you're being very realistic. I mean, if you look at so many of the world's great universal health systems came out of crises. I mean, the NHS came out of the ruins of the Second World War, as did the French system, the Japanese system, the Thai system came out of the Asian financial crisis. So in many respects, it is at times of crisis that, the countries do make the transition to universal health coverage. So I think it is a pretty good bet, but we'll just cross our fingers and wait and see. Well, thank you very much indeed. It's been absolutely fascinating. I've loved chatting with you. And any way we can help to move things on in the United States, do please let us know. I hope members enjoyed it as well. I'm sure you did. And we look forward to seeing the future debates. Hopefully they'll improve in quality next time round. And yes, we'll wait and see November. Right, best of luck. Thank you very much indeed for joining us.
Thank you. Thank you,
so
Cheryl.
much.
Bye all.
Wonderful to chat with you. Thank you.
Bye.